Great. So just sharing my screen, which you should now be seeing. Thank you so much for this opportunity. It's a real pleasure to be presenting to you today. So what I want to do in the next 40 minutes or so is just describe very clearly what a stepped wedge cluster randomized trial is. And then I want to introduce the ISWG trial as kind of an example of an implementation stepped wedge design. I want to describe the two most important statistical complications of this design. And then I want to review some advantages and disadvantages of stepped wedge cluster trials. And if we have time at the end, I also want to give you some available resources that you can use and maybe share with your statistician if you are planning a stepped wedge cluster trial. So as you know, in a standard parallel arm cluster randomized trial, the clusters, and this could be, for example, hospitals or clinics or even entire communities, are randomized to either the intervention or the control arm of the trial, and they remain in that arm for the duration of the trial. Post-intervention outcomes are then compared between the arms, right? So that is a standard parallel arm cluster randomized trial. In a stepped wedge, it's different in that all of the clusters start the trial in the control condition, and then they gradually cross over to the intervention until all of the clusters are in the intervention condition by the end of the trial. They never cross back, so it's a unidirectional crossover here. And note that rather than having the outcomes only assessed once off at the end of the trial, the outcomes are repeatedly assessed in each of these periods. So there are repeated outcome assessments from each of the clusters over time. All of this is coordinated in calendar time, by the way. So all of the clusters initiate the trial at the same time, they end at the same time, and these times of crossing over are entirely dictated by the design, by randomization, okay? And so this little diagram here is for a typical stepped wedge where we had 8 clusters participating and 2 clusters at a time cross over at each of these 4 so-called step times. All right. And so just to get the terminology straight, the rows typically are referred to as sequences. So clusters are randomized to one of these 4 sequences in this case. The columns are called periods. So these are all calendar periods of a specified duration. The times of crossing over are called steps. And then the duration between these steps is a step length, and all of that is specified by the design. And then the cells are called cluster periods. Might help a little bit with the terminology. Now, there are 2 main types of stepped wedge designs, depending on how the patients are identified or recruited. Now, I say identified or recruited because not every stepped wedge actually recruits patients. Sometimes, especially if we have routinely collected data available for outcome assessments, the patients might not even be aware that they are in a trial. They're not actively recruited. They just identified for outcome assessment and evaluated as part of the analysis. Nevertheless, in a cohort design, all of the eligible patients are identified and or recruited in the first period, and they are then followed over time. So the same patient is measured in each of these cells. And then, of course, that means the same, every patient is exposed to both the control and the intervention ultimately, right? In a cross-sectional design, on the other hand, and this design is also known as continuous recruitment short exposure design. In this design, there's kind of a continuous flow of patients into and out of the trial. And their exposure times are relatively short. So this means that in every period, there are essentially different patients identified. So an example might be a stepped wedge taking place in an emergency room setting, where patients show up for care, they get exposed to the trial, whether the that site is in the intervention or in the control condition, and then they go away and they have their outcomes assessed. Now, these outcomes could be assessed in the longer duration. So you could follow up the patients at 30 days or at 12 months or whatever, but the patients showing up the next day are different patients. So there's new patients coming in all the time. So that is called cross-sectional or continuous recruitment short exposure design. So with this variation, only about half of the patients receive the intervention and the other half receive the control, just like we would have in a standard patient randomized trial, for example. This is by far the most common situation, by the way. Now, the previous diagrams kind of assumed that the intervention can be switched on instantly. That isn't always possible. So especially perhaps if it's an implementation intervention, some interventions need a little bit of time to be implemented. It might involve training of providers, or it might involve, changes being made to the services that are delivered at that site. And so a transition period is a good idea. So a transition period is a period of time without any data collection to allow the intervention to be fully implemented, or to even allow that intervention to affect the outcome. Sometimes there's a natural lag before the intervention can even feasibly or plausibly have an influence on the outcomes. So these transition periods can be just a small portion of each of the periods, or it could be an entire period length, or even it could even be more periods. But either way, the omission of these periods where we are kind of pausing our data collection would have an impact on the power of the trial, so it needs to be considered in the planning stage of the design. So we have to account for that in our sample size calculation. And coincidentally, these periods where the intervention is implemented, those are actually the most valuable or the most important for the power of the trial. In fact, it's the period immediately before and in the very first implementation of the trial. Those are the most powerful, typically, in a stepped wedge design. So it's definitely important, if you're planning an implementation period, to account for that in your power calculation. Now, I'll just mention one more variation. It isn't actually essential to collect data in every single period, although it kind of, for the vast majority of trials, that is the case. If the data collection burden is heavy, some investigators like having an incomplete design where some of those periods are omitted. And the variation where each cluster contributes measurements immediately before and after the intervention is introduced, those are called staircase designs. So there could be, in the one extreme, just one period before and after, as I show in this diagram, or there could be more periods before and after. So these are called incomplete stepped wedge designs, also known as staircase designs. So I think we have to be a little bit cautious. The methodology for these designs is not fully fleshed out. I think there's been a lot of emphasis on the efficiency of these designs and trying to figure out which cells can I omit so that I have the least detrimental impact on my power. But I think far less attention has been paid to potential bias implications. So for this previous design, I'm a little bit worried about the sparseness of this design and risks of bias here. So I think a lot more thinking has to be done about the incomplete versions of this design. All right, so now I just want to give you an example. This is called the EPOC stepped wedge design. It's been published. The objective of this trial was to evaluate the effectiveness of a UK national quality improvement program to improve survival for patients undergoing emergency abdominal surgery. So the intervention was kind of implementation of an evidence-based care pathway. So they decided to choose a stepped wedge design. They had 93 NHS hospitals And some of these hospitals collaborated with each other, or they had providers kind of working at multiple institutions. So they couldn't randomize these hospitals independently, obviously, because that would lead to contamination. So what they did is they grouped the hospitals into 15 geographical clusters that operated independently. And these were then the units of randomization. So the clusters were randomized to start the QI program over an 85-week period. So one new cluster crossed over every 5 weeks. So the length of their intervals was 5 weeks. The primary outcome was mortality within 90 days of surgery. There was no patient recruitment. All of the outcomes were obtained from routinely collected data sources. Unfortunately, they observed no difference in mortality. A diagram is always very useful to understand this design, so I can highly recommend including a design diagram whenever you plan or publish a protocol or a trial report. And so here, the shaded periods are when the hospitals were in the intervention condition. The unshaded is when they were in the control periods. And you can see each of these periods, like 5-week duration. And there were 17 periods rather than we would have expected 16 periods, but there were 17 periods because they also allowed for this transition period, right? So there was the 1 5-week period in which they allowed the quality improvement program to be implemented. So the numbers that you see in each of these cells, that's just the total number of patients who were included in the trial in those periods. And obviously, because this is a continuous recruitment short exposure design, these are all different patients. So 8,482 patients in usual care, 7,374 in the intervention condition. These are, of course, all different patients. So please note that whenever you hear an argument that a stepped wedge has an ethical advantage because it allows everybody to receive the intervention, well, this shows that that's not a true statement, right? In a stepped wedge, it's not necessarily the case that everybody receives the intervention. So that kind of argument about the ethical benefit of this design is actually flawed. And so only half of the patients are actually exposed to the intervention here. Now, according to the consort extension for stepped wedge trials, it's very important that we have a clear rationale for the choice of this design. In the case of the EPOC trial, their rationale was, number one, we chose this design because we wanted to improve statistical power. And that is a valid rationale. It is true that with a stepped wedge, we can often have greater statistical power for the same number of clusters. I will get back to that point a little bit later. But also they said this design allowed all participating hospitals to adopt the intervention at some point during the trial. And that was attractive to them. They didn't say it had an ethical advantage, fortunately, but they did say that, well, it was kind of perhaps important to the sponsor or to the funder that all of the hospitals get an opportunity to implement the intervention at some point during the trial. All right, so now what I want to do is just highlight the 2 key statistical complications of this design. Now, there are others, but these are perhaps the 2 main ones. The first is that the intervention in this design is confounded with time. That's often a surprise to investigators because the reason we do a randomized controlled trial is because we want to avoid confounding by whatever characteristics might be, imbalance between the arms. In this design, there is a confounder introduced by the very nature of the design. I'll say more about that. The second complication is that we've got a very complex scenario surrounding intra-cluster correlations. You may be aware of the intra-cluster correlation coefficient being a very important parameter in a cluster randomized trial design. It refers to the fact that observations within clusters are correlated with each other. They are not independent. Well, it's even more complicated in a stepped wedge. Now, unfortunately, statisticians, even well-trained statisticians who don't have experience with this relatively novel design, may not be aware of these complications or how to deal with them. So let me just say a little bit more about each of these complications. The first one was the fact that the intervention effect is partially confounded with time by design. Why does that happen? Let's think a little bit about a before and after study, a simple before and after study. You might have a quality improvement program that's implemented at a hospital at a particular point in time. And the clinicians want to know, well, did this program improve outcomes? So they might measure the outcomes over the 12 months before and the 12 months after the intervention, and then do a chi-square test to compare the outcomes, or a t-test to compare the outcomes before and after. Well, we know that is a very, very risky study design to use, because if we see a difference from before to after, we all have no idea if that is actually because of the intervention working, or is it just a natural change that would have happened anyway. We call that a secular trend. In other words, were the outcomes already improving even before the intervention was implemented? Or is it just regression to the mean, or chance? Or is there something else that happened? So, for example, here, in this case, even though it appeared as if the intervention was effective, it's clear that if you connect the dots and you take monthly outcomes, for example, the rates were already improving even before the intervention was implemented. And actually, this intervention had absolutely no effect on the outcomes. Now, it's not quite the same in a stepped wedge. A stepped wedge is a step higher than a before and after design. The fact is that in a stepped wedge design, we do make before and after comparisons. So we do compare outcomes within the same cluster from before to after, but that's not all. Fortunately, in a stepped wedge, we also do have information between clusters. So within these vertical periods, we compare clusters who have already implemented the intervention to clusters that are still waiting to implement the intervention. So we do have that concurrent control. In our analysis, it all comes out in the way that we analyze. We're comparing the blue cells to the dark blue cells to the light blue cells. And that consists of the mixture of within cluster comparisons and between cluster comparisons. The within cluster comparisons are confounded with time. There could be a secular trend there. And so we say the intervention is partially confounded with time with this design. Okay, so it's just something to be aware of. The way we deal with it is we have to do a multivariable model. So in other words, we can't just rely on a chi-square test or a t-test like we like to do in a randomized controlled trial. We don't like to have to rely on a multivariable model to give us an unbiased answer. In a stepped wedge, we have no choice. We have to rely on a model. So the model has to adjust for time. It has to kind of remove the effect of the secular trend so that we can get an unbiased estimate of the intervention. It's never a nice position to be in because a model could be wrong, right? All right, so here's an example of these investigators conducted a stepped wedge. They randomized 37 renal centers in Australia to evaluate implementation of a multifaceted care bundle to reduce catheter-related bloodstream infections. So in their results, they monitored over 1 million catheter days. They observed an infection rate in the control periods of 0.32 per 1,000 catheter days. In the intervention periods, they observed 0.24 per 1,000 catheter days. So yeah, that seems really great. It looks as if the intervention worked to reduce the infection rate. But remember, we cannot trust those observed differences. That would be this is partially comparing changes from before to after. That cannot be trusted. So those estimates are not valid. It's not a valid description. Some of that could just be a natural improvement over time. So we have to do a statistical model. Fortunately, these investigators did do that. They did implement a multivariable model. And as you can see, after adjusting for the time effect in their model, the incidence rate ratio actually was indicating potentially a worse infection rate in the intervention period. So I'm sure that was not a very popular answer. And perhaps the investigators who were asking the statistician, well, do we really need to account for time? Can you check if that time variable was statistically significant in the model? If it's not statistically significant, maybe we can just remove it and report, you know, incidence rate ratio that's less than 1 that shows our intervention worked. But no, fortunately, they knew that they had to account for the time effect in the analysis. The second key statistical complication is that the intracluster correlation situation is quite complex. Now, it's already complex enough in any cluster randomized trial. We have to account for the intracluster correlation in our sample size calculation and in our analysis. But in a step wedge design, we have to account for additionally the over time correlation. So actually we have two types of ICCs in a stepped wedge. We have a within period ICC, which is a correlation among multiple people in the same cluster in the same period. But then we also have the between period ICC, which is the correlation among multiple individuals in the same cluster, but in different periods. And we would expect that between period ICC to be less than the within period ICC, because the further apart the measurements are made, the weaker the correlation is typically. So the ratio between the two, by the way, is called the cluster autocorrelation coefficient, in case you encountered that term. Nevertheless, so if we do not recognize this more complex correlation structure with a stepped wedge, we could end up having a sample size that is too small, in other words, an underpowered study. And our analysis also, if we ignore this complex correlation, will give us p-values that are too small. So the complexity here is that at the time of sample size calculation, we often don't know what those two correlations should be. I mean, it's difficult enough to come up with a single ICC. Now, if you ask me to help you do a power calculation for a stepped wedge, I'm going to ask you for two ICCs. Okay, so I mean, we do have some rules of thumb that can help us kind of guesstimate what that between period ICC might look like, but everything is just a lot more uncertain. It's just a lot more complicated. What I want to do now, and I think I forgot to put this one in my outline, but I just want to also mention two common misconceptions about the stepped wedge design. The first is that we don't even have to think about our intervention effect. This design works well regardless of the type of intervention. Well, that's a misconception. I'll explain to you why I say that now. And the second misconception is investigators often tell me, oh, I want to do a stepped wedge because it's less logistically complicated, because I can stagger the implementation of the intervention. I don't have to deal with a logistical scenario where I have to implement the intervention at the same time in half of my clusters. That's also faulty reasoning. Let me explain what I mean by that. So the first misconception is this idea about, I don't have to even think about how the intervention works. Now, the standard approach that 99.999% of step wedge trials use, it's the so-called Hussey and Hughes method. It assumes that the intervention works immediately and then it keeps working. So this is just a little diagram to try and illustrate that idea. So the blue line, this is just plotting out the time trend or the observed, the model data in the control periods. So that's assuming, well, that is before the intervention is introduced. It's just showing what the estimated secular trend would be, the outcome trajectory in the control condition. When the intervention is introduced, the model assumes there's a step change. So in other words, the effect of the intervention is the same regardless of where it is introduced. And so the two lines are parallel, essentially. I think people don't appreciate that this is the implied model when you design your stepped wedge trial using standard approaches. And these are the approaches that are in common use. the fact is that the intervention effect could actually vary over time. And there are two ways it can vary. It can vary with calendar time. In other words, the effect of the intervention in the clusters receiving it first could be different than the clusters receiving it later. And that could be because of seasonal variation. It could be because of external events like pandemics. And the second way that the intervention could vary with time is it could vary with the duration of exposure. So as you can see, some clusters receive the intervention for 3 periods, other clusters receive it for 2 periods, and other clusters receive the intervention for only 1 period. So it's possible that the strength of the intervention increases with time as they get more experience, but the reverse, of course, is also true. The intervention effect could weaken over time. So it's important to think about the type of intervention. If it's something like education, it could be that there is more of a gradual effect of the intervention. It doesn't remain stable over time. So the standard analytical approach may be biased. And here is a really nice paper by Kenny and colleagues that explored the extent to which our answer could be biased from the standard analytical approach. So I just want to quickly explain what this means. So essentially what they did is they simulated data under different types of intervention effects. The blue line is the true intervention effect. So you can see in the first diagram, the intervention is introduced and it works immediately and it keeps working. So this is the standard assumption and instantaneous intervention effect. In the second one, it takes 2 periods before the intervention starts working, but then it keeps working. So there's a bit of a lagged effect. In the third, it kind of, it has an effect immediately, but then it kind of levels off. So there's a curved effect. And then in the final scenario that they examined, there's kind of a slow effect, then it picks up and then it levels off. So these are the scenarios that they investigated. The orange is the actual estimated intervention effect from the standard analytical model. And the very surprising finding here is that in the second scenario, the answer could be completely wrong, even in the wrong direction, in the opposite direction. So if we analyze this trial using the standard method, it could tell us that the intervention was actually harmful, whereas it's just a misspecified statistical model. We're assuming an instantaneous treatment effect when actually there was a lag that wasn't acknowledged in the analysis. And similar for the other 2 scenarios. So this is pretty scary, and we actually have to do a lot more in thinking about the nature of the intervention effect that we are trying to estimate in our trial. The second situation is the logistical misconception, is the logistical complications. So investigators, as I said, often tell me that I want to do a step wedge because I think it's going to be logistically easier because I can implement the intervention gradually over time. I always try and explain to them, well, please be careful. The logistics may actually be more complicated than what you're used to in your parallel arm designs. And that's because in a step wedge, as I explained earlier, all of the clusters have to be ready to initiate the trial at the same time. So that means all the contracts have to be in place, the IRB approvals have to be in place, and they have to go when they are, so the intervention has to be implemented at the time they are randomized to. So they have to adhere to the randomized schedule of implementation. That can be very complex to pull off. In a parallel arm design, often we can do everything sequentially. So we can recruit the cluster sequentially, randomize them sequentially, and often the intervention is implemented sequentially as well. And so also what I always, what I say to investigators is that the step wedge is not the only design that allows a staggered implementation. It is also possible to do a staggered implementation in a parallel arm design, as I show in this little diagram here. Okay, so here is an example of a step wedge trial that was implemented across 8 wards in the Netherlands. So the orange boxes is where they were supposed to be in the control condition. The green is where they were supposed to implement the intervention. That's what was planned. The second diagram is what actually happened, and we can see that a lot of things went wrong. So some of the clusters implemented the intervention always immediately. They simply were not willing to wait. But then their enthusiasm kind of fizzled out and they never even completed the trial. They just stopped collecting data. Maybe there was an external event or something happening. I don't recall in this particular trial. Two of the randomized clusters, even though they were randomized, they never even got the trial off the ground. They were not able to initiate the trial on time and they never implemented the intervention. So the investigators tried to rescue the trial by randomizing two extra clusters kind of towards the end. But of course, it's too late now. So these were essentially observational data. They were not part of the randomized control trial from the beginning. So things often go wrong. And in fact, we did a systematic review of published step wedge trials over a 2-year period, and we found that close to half of these trials had at least one implementation challenge. So investigators should not underestimate the logistical complexities of this design. Okay, so now let me just quickly say, well then, what are the advantages of this design? Are there any advantages of this design? Yes, there are some advantages. The first, as I mentioned for the EPOC trial, there may be some benefits in that every single cluster will eventually get the intervention during the trial. Investigators do find this beneficial because they sometimes struggle to recruit clusters or institutions to participate in a trial when they know that half of them will never get anything. They will just be in the control arm for the duration of the trial. They have to do all of this data collection, but never get a chance to actually implement the intervention. So it could be a benefit to tell them, look, at some point, you're going to be able to implement the intervention. But please remember, you can also do that in a parallel arm design. You could offer the control arm the intervention at the end if you find it to be effective. The second advantage, and this one is really difficult to argue against, is that with a stepped wedge, you may get more power for the same number of clusters. So it could be that you will need fewer clusters to participate in a stepped wedge than in a parallel arm design. This is often, almost always the case, although I must say it's not always the case. So it also depends on the ICC and the cluster period sizes. The difficulty here is that we often don't accurately know the ICCs at the design stage. So everything is a little bit tentative at this stage. Now, the disadvantages, I think you may already have guessed, most of them increased risk of bias over parallel arm designs. I mentioned earlier, there's this confounding bisecular trend. We could have bias due to the time varying intervention effect. So those are concerns with a stepped wedge design. We cover some of these in the paper below if you're interested in more discussion about this. As I mentioned, the design is also more complicated to analyze and interpret, so you definitely need to involve a statistician experienced with this design. This design may also increase the total duration of the study necessarily, because we have to stagger the implementation of the intervention over time, and we have to have these repeated outcome measures over time. That increases the total duration of the study. And unless we have routinely collected data, this can be quite heavy in terms of data collection. The latter two may increase the risk of attrition as well. So I have no empirical evidence that attrition is more common in this design, but that's possible. And then also, of course, the logistical complexities of this design. So those are some of the disadvantages. All right, so I think I have almost reached the end of my talk, but I just want to show, and I'm happy to make the slides available if helpful, some available resources to you. We have a nice tutorial on sample size calculation for the stepped wedge. And in fact, it also covers other multiple period designs like a multiple period cluster crossover or even parallel arm designs with repeated outcome measures. All of those can be handled with a simple calculator. It's a menu-driven calculator. Doesn't require any kind of statistical coding knowledge. It doesn't require a statistical program. So it's quite easy to use. Dr. David Murray from the NIH also has a very nice sample size calculator and website that you can access. If you're interested in finding out a little bit more about how you can obtain estimates for the ICCs, if you happen to have routinely collected data available, we also have a tutorial about that and a nice shiny app that can help you calculate these ICC parameters that you need. There's a nice website, Queen Mary University of London. And then if you are kind of debating whether a step wedge is right for you, there are several nice papers and seminars, and also a very nice blog by Richard Hooper that covers some of those considerations. Okay, so just in summary, this is a novel type of cluster randomized trial design. I don't want to be completely negative about it. I really enjoy helping investigators design a stepped wedge. But we definitely have to go through kind of a thought process at the beginning of the consultation to decide if there really is a good enough rationale for doing a step wedge. Perhaps in some cases, a parallel arm is just going to be so much better for you because of the additional complexities and the increased risks of bias of this design. So we need a clear rationale for adopting it. I always say, when feasible, a parallel arm design is probably the preferred design, but I must be honest in that I haven't always, or I have very infrequently been able to completely talk people out of doing a step wedge. Once they really want to do a step wedge, it's kind of difficult to persuade them not to do this design. So I will stop there. Thank you very much.
Monica, terrific. Thank you so much. So I'm going to take the prerogative of first making two very brief comments. And Don, as usual, will be amongst the first to ask a question. So I will turn to him once I've asked my question. So my two quick comments are really about some of the downsides. And just to add to your list of things, on the sort of time-varying intervention effects, there's also expertise in delivery of the intervention. When I begin delivering an intervention to one site, 6 months later, 8 months later, I may be more expert or have identified the core components, key in implementation research, as in the functional components, and those may also change over time. So just perhaps to add, or for reaction if you have. Another, to add to your logistical complications, ultimately, all clusters must get the intervention if it's set up that way in the traditional design. And that effectively doubles the amount of resource that I am required in a placebo-controlled or usual care type setting. So with that may also be a constraint in the application of these designs. So here's my question. So you feel free to comment on those or challenge or respond to that. Here, my question is really about this, I think, provocative idea of statistical efficiency, which I think, perhaps which may, from what my understanding, and you can comment on this, depend upon, is it, continuous outcome, an ordinal outcome, logistic outcome, that may have something to do with it. But there's this trade-off between that concept and these two levels of correlation, which of course in traditional designs can blow sample size up so easily. And so I'm wondering if you can give us a little bit of intuition, like are there general parameters that will say to us, in fact, I will gain power this way, and maybe I need fewer cluster units than I might have otherwise? So that's really the core question that I have to offer to you.
Yeah, let me just address the latter of the 2 points, the additional disadvantages that you were so helpfully pointing out. The one that you mentioned, the second that you mentioned, was that it doubles the resources that you need in terms of, staff required to implement the intervention and other costs associated with the intervention. On the other hand, though, consider that you may need fewer clusters. And so that is an important consideration. And that's the reason why whenever I'm asked to help with a stepped wedge, I always do the calculation for both a parallel arm design and a stepped wedge, just so that I can have that clear in my mind. So how many fewer clusters am I going to actually need for the stepped wedge compared to a parallel arm cluster randomized trial? I often find that there's a substantial difference between the number of clusters required for a stepped wedge and a simple parallel arm design, where you just have one measurement in every cluster, kind of at the end of the trial. But what people forget is that you can also do a parallel arm before and after cluster randomized trial, which can substantially boost your power as well. So the right comparator, I think, is actually for a parallel arm before and after cluster versus a stepped wedge. And often when I show people the diagram and I say, okay, well, with a parallel arm before and after cluster, you will end the trial much sooner. And, you may require a few more clusters, but it's kind of at the benefit of having a shorter trial. They often, kind of see the benefit of that. All right, so then you were asking about intuition, about kind of when do we benefit from doing kind of a stepped wedge rollout. And so the statistical knowledge that we have is that when the intra-cluster correlation tends to be higher, or the cluster period sample sizes tend to be higher, we get a bigger benefit from a stepped wedge. That's kind of a rule of thumb. But again, it's very difficult to give you kind of definitive cutoffs for that. And like I say, the problem is, when we design these trials, we have to rely on guesstimates for these correlation parameters anyway. So the important thing is to run through a few scenarios at the design stage.
Thank you, Monica. Okay, Dawn, please.
No, that was fabulous. I really enjoyed it because I often tout step wedge as being a very good design for quality improvement type of interventions where there's natural clustering and you can't avoid it. So I want to just briefly comment on what you said about the EPOC trial, because it'll set up the question I have for you. As you know, there were 32 components to that intervention. There were 5 weeks for some sites to implement them. The clusters were every 5 weeks. The technical support was extremely light, and most sites reported in a really good process evaluation that was subsequently published that they hadn't even done PDSA testing regularly, which is obviously a core component of quality improvement. And that may in part explain why a study done at the same time is a large collaborative with, I don't know, there were 30, there were a lot of people in it, showed a marked effect. Of course, there was no counterfactual. Collaboratives are riddled with bias as well, but it was a little unfair to take a cluster randomized trial, which supposedly is more rigorous, and then to magically intervene without any real thought about its effectiveness. But that leads to the question. Very often I will see quality improvement people express admiration for step wedge because they say it allows me to learn about my implementation in the early steps. And of course, if you're going to learn about implementation in the early steps, which I think is really great, unless you have a really long run-in period, but context, all that stuff, we talk about, you're learning. And then if you change the implementation, then your power immediately starts to erode and the complexity of analysis becomes very difficult. So that is side by side with what ought to be a data safety monitoring board, because you can't keep adding clusters if the thing ain't working. And exactly. I often don't see a data safety monitoring board because it's not a randomized controlled trial in the usual sense. So could you comment on that? I think it's even more dangerous in some ways than what you said.
Yeah, I'm a little bit surprised when people say that they kind of improve the delivery and they learn over time. But, what is a pilot trial for then? I would say that you kind of have to sort out all of those issues in advance of the trial. And to me, it makes estimating the true effect of the intervention so much more difficult. So how are you going to now estimate the true effect of the intervention? Are you kind of going to do a subgroup analysis of when the intervention deliverers are, most experienced, or, so it's kind of hard for me to get my head wrapped around that.
Yeah, well, I think part of the problem is the pilot trials in most funding mechanisms are not of sufficient breadth and scope to allow for real contextual inference.
Yeah.
So, and in fact, pilots were done here, and they were largely ignored in the design of the trial because they weren't considered contextually rich enough.
Yeah.
And what I would offer, Monica, is, to build on the very first point that I made, which I think Dawn is making in an explicit method, even if it's not explicitly learning, there's implicit learning as the trial progresses, which is a fundamental bias, which is impossible to address.
Yeah, and you can solve the problem in part by doing what a good study should do, which is to have set adaptive points. You say, after 4 clusters, this is an adaptive trial. We will make a change based on what we've learned, and everybody, including the evaluator, will know it.
There's another consideration as well. There's increasing interest now in so-called batched step wedge designs, where you kind of have mini step wedge designs in phases. So you have, 4 clusters participating in the first batch. They complete the step wedge. And then there's another batch of newly randomized clusters that complete the trial. And there could be multiple batches, and each of these batches could have their own secular trend and their own intervention effect, and there's kind of an average pooled estimate in the end. So that could be a solution for that type of situation.
Perfect. All right, Nancy, over to you.
Super interesting and helpful. So first of all, thank you very much. I learned a lot. One of the things that really struck me in your talk was the graphs of the modeled effect and versus the actual expected effect. That and also the importance of accounting for time in the modeling. And this actually came up in our journal club the other day when we looked at a step wedge study. And I was wondering if, as readers and consumers of papers that have used this approach, are there things that we should be looking for in the methods to make sure that they have accounted for time appropriately, or that the methods match the expected influence of the intervention, kind of as laid out by your diagrams?
Yeah, I would definitely check. The number one thing to check for is whether they say something about their analysis accounting for period effects. So did they say we conducted a multivariable model, a regression model, which included period or time as a term in addition to intervention? So at a minimum, your analysis has to include 2 fixed effects, period and intervention. And then for the correlation structure, I always look to see if they, obviously at a minimum, they have to account for the intracluster correlation. So that means their model also has to have a random cluster effect. But to allow for that distinct within and between period ICC, they should also say something like, we also included a random cluster by period interaction. So that allows for that ICC to kind of decrease with increasing separation over time. So those are the minimum things that I would look for. In terms of the intervention effect itself, I don't think I even know of an example where they did consider this time varying intervention effect. I think it's almost universal that all of them just estimated a time averaged effect. In fact, we are now collaborating with Professor Jim Hughes and colleagues to empirically reanalyze previously published stepped wedge trials, allowing for a time varying intervention effect, because we want to see how often this is a problem. And I think it's going to be quite often because the types of interventions that we see require some sort of a, expertise or something that kind of gradually improves or perhaps weakens over time as well. So I think there, if investigators discuss it, they should perhaps just say something like, we included multiple terms for the treatment effect over time, or something like that. A time on treatment effect is what it's actually called.
Perfect. Julie.
I'll just quickly layer on, actually, my question was related to both Nancy's and Natisha's point about adaptation and thinking about implementation and research. But the point I wanted to add on to Nancy's is that in implementation research, we're often interested in durability of effects and sustainability, which by definition, we would expect to potentially see some differences over time, or explicitly be trying to see if there are differences over time in these time, like, and not assuming time fixed effects. So just to kind of add on, and where I was curious if you'd thought about it. Clearly you answered the question. So just to add on another potential use case when you're working on that project. So thank you. This is great.
Yeah, that's a good point.
Excellent. Steve.
Yeah, I'll just ask the question whether in pragmatic trials it ever makes sense to do a stepped wedge. And let me say what I mean by that. You know, not only are these issues with respect to people incorporating more skills as they go forward, often happens even in the best of designs with pilot studies. But with it in implementation research, we always talk about context, you know. What if the context is constantly really changing? Environmental disasters, economic changes of the healthcare system, COVID. I'm so grateful to PCORI for waving off a step wedge design that I proposed on preventing COVID-19 and group homes for disabilities, because during the trial, the base rate of COVID changed, the variant changed, the interventions that people were using in the comparison arm changed. It would have been a total time variant disaster. Not to say that if it had been a standard, which we eventually did, a standard kind of sequential, you know, blocked randomized trial where, you know, still each time period was different, but it was kind of internally, you know, re-randomized. So I guess I'd ask the provocative question. And you've talked about all the negative, but also the positive, and the power issues are compelling. And yes, when we sell interventions, quote unquote, to organizations, the fact that everyone gets the thing is truly a selling point, even though, as you mentioned, it's not quite true. So what do you think? If the real world, if we assume that the externalities are never really fixed, they're always dynamic, and if we assume that change does happen, sometimes with the intervention, does a step wedge really assume and require really fixed context and fixed intervention, or are there ways to compensate for that through statistical methods or adjustments, as you've alluded? If not, maybe we should never do them. Even though I love them and have done them, but anyway, what do you think?
It's really nice to hear you say that, because I do agree that, you know, we really have to think twice about adopting this design. Now, that said, you know, statisticians are working on methods to overcome this. So one thing that you can do if you are expecting a time varying treatment effect is to code your statistical model accordingly. So rather than just having a binary intervention indicator, you know, rather than just control versus intervention, you may have a categorical term for your intervention according to, you know, maybe you think in the first period they're kind of 10% strength, and then in the second period it's 30% strength or whatever. So you can kind of postulate the strength of the exposure that you think in each of those periods. But the question that I have is, based on what are we going to specify that? How are you going to come up with that in advance of the trial? I mean, you have to pre-specify your analytical plan. You have to do your sample size calculation accordingly. And how are we going to come up with that? So all it does is creates more assumptions, and assumptions could be wrong. And so, you know, in the end, I think falling back on a standard parallel arm design where you have a concurrent control created through randomization, as you said, that's what you did. That is just, I think, the best. We don't have to rely on statistical model to reduce that bias effect.
It does, in terms of outer context, which is what implementation scientists always talk about. And context matters. If we do take the belief that context always changes, is that okay? Or do you really need to have fixed context in terms of the externalities, the outer environment and the leadership? I mean, all these things change in real organizations, you know, all the time. So what do you think? Does context matter?
I think context is absolutely important. So if investigators describe a situation where things are changing all the time, I would definitely say, look, let's not even talk about a step wedge. That's just going to be a nightmare. You know, you really need a stable environment to allow you to implement this
Thank you.
design.
Yeah, and Monica, your provocation of a pre-post parallel group cluster randomized trial may begin to solve some of these problems. So with that said, I think we've reached the top of the hour. This was a fabulously useful, fabulously clear, very practical, and frankly, from somebody who is steeped and expert in this to sort of both tell us the strengths, but also the warts of these, that couldn't have been more useful. So we thank you all we thank you so very much for spending time with us, for sharing your slides in advance. There are resources here that many of us will want to see, and we thank all of you for joining and participating, and we'll see you next month. Monica, thank you again.
Thank you.